Now, the most common form of language impairment is specific language impairment, and that's defined really as we don't know. We don't know why this child's got problems. They have, and they seem resistant to the things that we do with them, and therefore we call it specific language impairment, which is, as I say, a fancy term for we don't know. We know that more boys have it. You know, my caseload is filled with about 3 times as many boys as girls. We know that it runs in families, and we know that so-called traditional therapy and traditional teaching doesn't seem to have much of an impact. They really have to have a very intensive approach to catch up. And across the country in the past, there's been things like specialist language provisions, like language units, but these tend to be changing now. They're either being lost through the cuts, through integration, as the debate was this morning. It's having a real effect in that these children getting statements, or increasingly not getting statements, just getting School Action Plus, and being seen in the mainstream by teachers who are given advice by therapists, but not direct therapy. And you can talk to me afterwards about my personal views about that. The main thing about SLI is that it affects anything between 3 and 15% of children. Most people quote around 7%, 67% of children, and that's true of any population anywhere in the world, wherever you go. So there's definitely something going on genetically, biologically, environmentally that causes that percentage of children to have very, very extreme difficulties with language. So again, we'd avoid diagnosing SLI until about the age of 4 because of this late blooming. Lots of children who appear very, very disordered can suddenly come right, and we don't know why, and no one can tell us why really. We know the factors behind it. There's a big study going on at the moment in Victoria in Australia, and they thought very confidently they'd be able to spot the children very early and follow those children, and they found the children that were normal at 2 and 3 might go on to just plateau and have difficulties with language later, and the children who were fine they weren't the same children. They're all over the place. So although early intervention is very, very important, we need to make sure that early intervention is quite widely available, because we really aren't confident that we can spot children accurately when they're very young. After the age of 4, that noise in the data, if you like, really, really starts to come together, and you can spot the children much more obviously because the other children have started to move away from them in terms of language skills. So, the role of the speech and language therapist. This really is how most services are run, in that we would assess them, and if they had poor home language skills and poor English, then it's suggested that they've got a core speech, language and communication, an SLCN difficulty. If they've got very good home language, they've proven that they've got the mechanisms to acquire a language, so we would expect with the right input that they would go on to be successful additional language learners. A lot of children that are now in mainstream, as was referred to this morning as well, are children with other special needs. So language impairment might go in hand with intellectual difficulties, with developmental difficulties, with genetic syndromes, which we're now getting much better at spotting. So a lot of the kids, it was unheard of for children to be genetically profiled, and now it's almost routine that we're getting those spotted, which is great because the parents then know the reason and they can put in touch with support groups. And I think for parents it's really important to know why their child's having these difficulties. So as I said, language delays is perhaps our most common diagnosis in speech and language therapy, but I'd like to try and change that with people if I can. Also, delay, when we're coming on to bilingual children, delay compares children with their peers. So if I have an English-speaking child who's only ever spoken English, I can pick any number of assessments off the shelf and say exactly what age equivalent they are, and give the range, and the percentile rank, and the standard score. I went to a conference in Wales just the other month, and the therapist said to me, won't it be great when we've done all this research into Welsh and we know the norms for Welsh, because all the bilingual children I'll be able to diagnose. I said, no, because you'll only know what Welsh monolingual children are like. How do you know if this bilingual child has had 80% input in Welsh and 20% in English, or 10% in English and 9% English. You just don't know the balance. So even when we know the language pathway for all the languages on the planet, which is unlikely, it's still no use to bilingual and multilingual children, because we're comparing them with a group that they're not the same as. So again, when we're writing statement reports, when we're writing assessment reports, I use descriptive information. I say, in my professional opinion, this child has the following skills and has the following deficits. I don't use normative data, and we liaised with our education authority to make sure that they would accept that for entrance to things like ICANN units and language units and statementing procedures, because it would be discriminatory to quote norms and would emphasise when children have got normal home language that they've got special needs in terms of SLCM when they haven't. There is an argument that we should slightly overdiagnose difficulties with children who are bilingual, because that way we spot more of them. I don't mind assessing more children as long as we assess them in their full range of languages, so I can either say, yes, you don't need to worry, this child's going to be fine. So, one of the most challenging things, and most of my career and lots of other people's career, we've been trying to find out how to do this. How do we differentiate those that are delayed, those that have got a central language disorder that's going to affect all their language learning, and those that have just got normal EAL patterns? And the English data I collected during my PhD, kids do make mistakes that look like language disorder. So if you only assess them in English, you will falsely label children with normal EAL as language disordered when they're just not. The only way really to do them, there's two key ways that are emerging, is home language assessment paired with English language assessment, and then a skilled professional giving an overview of the balance, which we're always being taught about holistic approaches to children. I think that's a really good way of doing it. For a very, very small number of languages, people are always saying to me, can't we just do English assessment and see how they do with it? Now, in the 16.5 years I've been a speech therapist, I've only had one family I couldn't find an interpreter for, so I don't really like to go down that road too much. But for that family, we did do this kind of using the child as their own benchmark and seeing how quickly they developed language skills in English. So there's that approach as well, and I know definitely researchers looking at that way of doing it as well. So, evidence for language therapy. So, say we've diagnosed this child and they have got language impairment, how do we go? Surely it's very easy to then help this child. The research is bleak, to say the least. Speech and language therapy is a very small profession, and research is thin on the ground and quite depressingly small. This quote here kind of gives a taster of it. There's relatively little evidence supporting language intervention practices that are currently used with school-aged children with language disorders. So we don't have anything in our arsenal that is really, really effective for these children. There's mixed evidence, so kids with expressive language difficulties have better outcomes, but the ones with receptive comprehension language difficulties, we know have very, very poor outcomes. And the most widely used scheme, I'm sure plenty of people have heard of the Derbyshire language scheme. No one's ever evaluated it. It's a scheme, it's been developed, it's widely understood by speech and language therapists and quite a few teachers, but it's really never been evaluated systematically in a controlled study. So, again, watchful waiting was compared with speech and language therapy, no difference. So I kind of thought, I'm in the wrong career. I could just watch these kids. It'd be a lot easier, you know. My waiting list would be shorter. So, what is the impact? What happens increasingly is that therapists withdraw from language work. They focus on speech work, and I don't know what it's like in your area, but in our neighbouring areas, people won't see language kids. They'll assess them and go, here's some sheets, go away and do your best. And I don't think that's very good, because it's in my job title and I feel it's the most important thing we do. So this cutting in funding of preventative work and this cutting in funding means that therapists are retreating because there's no evidence. Commissioners are saying to us, well, your work's useless anyway, stick to the speech, the lisps and the funny sounds, and we can get our money's worth. And there's this assumption, well, they're just delayed, they'll catch up. And if they're bilingual, more so. They're learning 2 languages, that's why they're slow. So, how do we address that?